Welcome to Talkin Maine with Tom Saviello, the bow tie boy. Yep, that's a bow tie. Well, today I brought my own psychiatrist in. I figured I needed all the help I can get. If I had known they were going to have a couch here, I would have moved it in so you could watch it. Kristen, welcome to the show.
Thank you so much.
Thanks for taking the joke that I just made.
Oh,
but
sure.
you did show me that you have a tattoo on your body that's got a couch on it.
I did.
So that's great. So welcome. I mean, this is part of our series as we work with Franklin Memorial to talk about some of the different services over there.
Yeah.
And you're very excited. You've come up here from Philadelphia to Maine, and I'm very glad to be here. But tell us a little bit about you and your background before we talk about what you do at the hospital and,
Sure.
and how you think you can provide services to the community.
Sure. So, like you mentioned, I'm from Philly, and I actually, before med school, I was a nurse, and I was a substance use nurse in Philly. After that, I went to medical school at UNE, so came up to Maine, and that's really where Maine stole my heart. I left a piece of it here, I think, when I went back for residency in the Philadelphia area. I was at Cooper in Camden, New Jersey, and then at a hospital in Atlantic City, New Jersey as well. So that was for 4 years, and then I came up here from there. So
you right after you finished your residency, you came up to Franklin Memorial.
Yep,
Cool.
that's right.
Yeah, because
That's
I
right.
know one of the things that we really lacked in services up here is psychiatric help, because some of our guys that were doing that have retired.
Yeah.
And mental health is a really significant issue that people don't realize. And I share some of the experiences that I've had with people that have had struggled. And so tell me something about what's your goal at Franklin Memorial?
I want more people to be able to get the care they need. There's a lot of people that kind of struggle with mental health issues that aren't able to access that care. So I have some ideas for strategies. Some of them are to get more psychiatrists and more nurse practitioners or PAs that are interested in mental health and want to do that work. But while that remains difficult, an important aspect is the integrated care model, which is where I work really closely with primary care docs.
So to explain that a little bit. What is that integrated care module?
Sure. So right now I'm in the primary care office, the internal medicine office, and I work really closely with those docs. They're right next door to me, and we are constantly talking about patients. So for now, some of the things I'm doing is I'm seeing patient for maybe 1 or 2 or 3 visits, and then they'll be back with their primary care doctor, but I know them at that point, and I can help the primary care kind of manage as issues arise now that I have that background with them. So it's more of like a consultative model. Anyone who really needs to stay in my service, I'll keep a small panel, but that's the way I'm trying to do things. With peds too, I'm seeing children.
Remember, pediatrics.
Pediatrics,
Okay.
Sorry. So with the pediatric patients as well, I've tried to kind of make myself visible in that office. And with the family care offices and the family care doctors over at Livermore Falls, that group there, and just be kind of a presence so they can ask questions about mental health care to me, try to manage it, and then if they can't, the patients can come see me for a few visits, 1 or 2, and then back to primary care. That's how I envision things going for now while we're building up our services.
So tell me some of the things that, and obviously I don't want you to talk about patients, you can't do that.
Sure.
I know that.
I know
but
that
some
too.
of the things that you work with people on. I mean, as I shared with you when we came in, I've been around people that are manic depressants. I don't know if that's the right terminology, that's what I call them, but where the one lady who was, when she was manic, she literally wrote a 40-page manifest about how her husband and I were going to quit our jobs and we were going to open a bed and breakfast up. And
Yeah.
I was going to cook chickens in the back and her husband was going to manage the business. And so we
Yeah.
patiently listened to that. And the next day she was in St. Mary's because she was so depressed.
Yeah.
And so I know about that. I've been exposed to that a little bit. And I'm convinced to this day, my mother was a very depressed woman because of some of the things as I look back on it, how she acted about stuff. So, but those are the 2 ones we always hear about.
Yeah.
Other than the fact, and I don't know why they ask it when we go into the hospital, are you feeling safe today? Well, yeah, I think so. I mean, does anybody ever say no?
Yeah, so there's some better ways to ask that I could get into later. But as far as the disorders that we kind of work with, and I like to say in mental health, I live in the gray. It's not like cardiology. It's not like internal medicine. It's a constellation of symptoms, and each patient is unique. And really, we focus on modifying the pathologic process as best we can, which that's really through the work and through the therapy and through the behind the scenes stuff. And while we're doing that, we manage symptoms with medication. So everyone is a constellation of symptoms. No one really fits all of the criteria, but some of the disorders you would hear about, it would be like generalized anxiety disorder. That's the most common. And that's just excessive worrying, sense of impending doom, jitteriness, like some sort of muscle tension. It can manifest in your body. Major depressive disorder, which is the depression side of things. And that affects your sleep, your interest in doing things, your energy, concentration. It can affect a number of aspects. And then you kind of get into some serious mental illness, SMI, you'll hear that abbreviation. And serious mental illness includes things like bipolar 1 disorder, which was formerly known as manic depression.
So, I was just going to say bipolar. That was the other. I couldn't remember the word, but that would describe it, yes.
Yep, bipolar 1 disorder. And then some of the psychotic illnesses like schizophrenia or schizoaffective disorder. So schizophrenia is characterized by having some component of hallucinations, visual, auditory, some component of delusions, and then really like a flattening, like you don't have a full range of emotions. That starts to come out too. So that's there's some of the big ones that we treat. Of course, there's a huge component of trauma and stressor-related disorders. The one most people have heard of is PTSD. A lot of times when we think about post-traumatic stress disorder,
right.
A lot of times when people hear that, they think about the military. Right. That's one of the first things. It used to be called shell shock way back in the day. But PTSD occurs in more than just the military. There's so much domestic violence and other traumas that people really live through, and accumulated traumas just from growing up and living in their circumstances, that we see a lot of trauma disorders.
So how would that manifest itself with someone that has, not necessarily from the military? I understand that a little bit better because they have seen things that, God forbid, that they don't want to see, and it comes back to them and it affects how they act and what they do. But how would you see that from a domestic violence situation?
So it's the same idea. I mean, 1 in 3 women can be victims of intimate partner violence. It's a little bit higher for men, but men are also victims. And that experience that you have when you're afraid for your life. So the question I ask in session with people is, have you ever had a time where you were afraid for your life? And a lot of people have.
Yeah.
A lot of people have. So whatever that is for you can kind of lead to these symptoms ongoing.
So if I've had that, is there something that triggers it? That I get into a similar situation and I become anxious, or how do I manifest that when it comes out?
Yeah, so a lot of what happens is people will become like afraid to go outside sometimes, or in crowded spaces in like a grocery store. Sometimes there'll be something that triggers. It kind of depends on what your circumstance was. A lot of people are really plagued by nightmares or flashbacks that can just occur at any time. And then there's even a component of, we call it dissociating. So it's where you kind of float off, and it's your body's way of protecting you from that trauma. You needed to forget about it and almost blank it out while you were in it. So when memories of it come up in your subconscious, you might kind of go out for a little bit.
It's almost like having an out-of-body experience. You're kind of watching what's going on, but you're really not engaged in what's happening.
Yeah, it's a protective measure because of what it's not great, it's bad what's going on, so your body's trying to protect you.
Wow.
Yeah, so the trauma, I think, doesn't get enough play, especially in any sort of community that has a lot of adverse childhood events. We look at something called ACEs, they're adverse childhood events, and it's just bad stuff that can go on in your childhood. And when you have a lot of those, it puts you at a greater risk for a number of psychiatric disorders, including post-traumatic stress, including substance use disorders. Huge correlation there. So I think that's important to evaluate with every patient.
So go back to the manic depressant. Mm-hmm. I kind of shared what I observed. Yeah. Tell me a little bit about the symptoms that are related to that.
Yeah, so bipolar 1 disorder means that you've had a full manic episode, and a manic episode is 5 days of not sleeping, elevated mood. So I'll ask people, have you ever had a period of time where you were awake for 3, 4, 5 days in a row? You had tons of energy and you were the opposite of depressed. So that's kind of how the line of questioning goes. The manic phase gets a lot of play because it's an interesting phenomenon to observe, but really the depression that's in bipolar illness is a very difficult to treat depression. And that's why it's important to evaluate. Some of the medications we use to treat depression, major depressive disorder, can make mania worse. So when we're treating the depressed phase of a bipolar illness, you can kind of cause a swing. It's possible. There's also bipolar 2 disorder, and that's when you've never had a full mania, but you have really bad depressive episodes.
So your dip down is significantly lower than the high that you get up to.
Yeah, and there's a lot of exciting talk in psychiatry. A lot of people will think maybe everything's a little bit of bipolar illness. There's a bipolarity to all depressions. So that's just nerd stuff that I'll get into with other psychiatrists.
Well, I need all the help I can get, so we may need to get to the nerd stuff. Well, that's fascinating, because is there parts of the brain that are specifically affected by these things, or is it just a general, the brain is so complex. I mean, we don't know what, 90% of it really does. And so are there places in the brain that one can say that whatever happens here drives the manic mode or the depression mode?
Yeah, so sorry to interrupt you.
That's all right.
That's a tough one. So everything is a hypothesis in psychiatry. That's part of the gray.
You got to remember, those doctors are still practicing, because when you say he's a practicing doctor, and I said one of these days they're going to get it right, just do it. So, but go ahead.
We have some thoughts about it, and most of it involves pathways. So like in psychotic illness and in Maine, we look at dopamine a lot, and dopaminergic pathways in the brain that kind of extend from the frontal lobe, which that's going to be your stop, like, hey, no, maybe you shouldn't take your clothes off and run into the street. Maybe let's not do that.
Oh, that's the part that tells me to do that. Okay.
Yep. And then kind of extending to other parts in more in the center of your brain that are like, no, do whatever you want, or, no, you're hearing this voice. It's telling you to do this thing. You should do that thing. So, but that's all really hypothetical and gets into some kind of interesting neuroscience-y stuff that I'm not sure I buy yet.
Well, see, it's interesting because I remember when I was in the legislature, obviously addiction is a bigger issue, or huge issue, not bigger, but huge issue. And the person that was talking about it said that in drug addicts, the parental side of the brain is lost, that the pleasure side of the brain takes over, because they're saying, you really shouldn't do this, but boy, it feels really good.
Yeah.
And over time, this part, it doesn't physically, but takes...
You're hijacked, yeah.
You're hijacked from the parents saying, don't do this, it's not right.
Yeah.
And it takes a lot then to reverse that.
That's right.
So that the person gets back and does have the parent to say, I can't do this. I mean, I know some recovering addicts, one of them's over 30 years, and he tells me the story. It says, once you get that first high, you never get back there again, but you're always trying to get back there. And the parent, the pleasure part you're searching for in this part is saying, keep going, it's gone. I mean, is that close, or?
So substance use disorders, which are very frequently separated out from mental illness, I have no idea why they should be in the same home.
Yeah, I think so.
I feel really strongly about that. I've never met anyone with pure substance use disorder. There is a component of depression, anxiety, childhood trauma in most of the people that I've met that deal with substance use issues. That process in the brain is a little bit better understood. There's an area of the brain called the Nucleus Accumbens. It gets a lot of play. It's a reward center in your brain, and it's very excited with drug use. And essentially, it takes 1,000 repetitions to do something differently to kind of reverse that. So you are really fighting every fiber of your being when you're trying to make a different choice besides using a drug. And it's different for different drugs. Methamphetamine has some of the highest of that, even higher than some of the opioids that we hear about. So
wow. See, when we think about a baseball swing or a golf swing, it's 28 days. to change that. It's 28 days to change that pattern back to the new pattern that you want to use if you're in a bad habit. And then I do think of abuse situations. Somebody says it takes 8 times before a person is being abused by their spouse, man or woman, 8 times before they successfully can get out, because they get back into this pattern. And as much as, what I understand about it is that they become comfortable. I mean, they don't like it, but they know what to expect. When they go out and find somebody that's really nice, they just say, well, wait a minute, at some point they're going to flip out on me and do the same thing that so-and-so did to me. And so they stay in that bad spot because it's comfortable. Am I close there?
There can be fear of the unknown, and I think I would love to come back on any time to discuss substance use or domestic violence in more detail.
I'd love to do it. Great.
But yeah, there could be some component of that. There's also a fear of women are at most risk for being murdered when they leave a domestic violence situation. So there's a lot of nuance to that.
So let's go back to what you really came on here for. So tell me, so how do you then, so you do your work with a combination of drugs as well as psychiatric work of helping the person work through the situation, the diagnosis. So how do you do that? I mean, that's got to be a challenge in itself.
Yeah, so you need patient buy-in, for sure. That's important. That's part of my job, is to get patients interested and motivated into the change that they want to see. So I ask a couple questions to everyone. I say, when's the last time you were emotionally well? And maybe if I can hear about what that time was like, we can begin to replicate that again. But a lot of times it's like, well, I had a job then, I don't have a job now. Well, I had my spouse then, I don't have a spouse now. So I need to work with the new normal and see how we can help someone move forward. I tend to focus on function and helping people become functional in the way that they need to be. That looks different for every person. I say everything is 5 to 10%. The meds I give you will help you 10%. If you find different coping mechanisms, that might be meditation for some, that might be journaling for some, that might be going for a run, whatever it is, that might get you 10%. Therapy might get you 10%. We got to add up. We get you to 60% better, we're in pretty good shape.
Yeah.
All of us are walking around at about 60%.
Yeah, no, I was going to say, it's interesting, and having been in the legislature when we dealt with Medicaid expansion, I had a lot of people say, well, that person's a perfectly healthy person. I said, you don't know what's going on in their head. You can't tell. They may look totally normal, but they're in turmoil, and you've got to help them figure out how that turmoil is because they want to be functioning in the community, and they can't do it with that situation.
Yeah, and functioning, again, like I said, for different people is going to be different things. There's people that, their goal is to get their kid back. And okay, what do we need to do in your life for that to happen? There's goals, someone hasn't been able to work because of whatever symptoms they're having. We need to be able to get you to work. What does that look like? I also tell people, I'm the GPS. You're steering the ship. So, I'm going to offer you suggestions. I can't make you take my suggestions. I'm staying on the ship with you. Might be a bumpy ride. Maybe we have to turn around. But I won't abandon the ship. I'm not jumping overboard. But, we'll get where we need to go. If it looks like this, fine. If it's a straight shot, that's good too.
Well, that's good. That's showing flexibility because, as you said, everybody's going to be different in how they figure out how they're going to cope with all of this stuff. So you're doing this now. Well, let's go back to some of the other schizophrenia. Let's talk about that, because is that the one that people have voices in their heads? And do they really then split into 2 different personalities, perhaps?
No, that's different. That one's different. That's like a dissociative disorder.
Okay.
Very controversial and exciting. We can talk about that another time too.
All right.
You'll have to invite me back.
I will.
So schizophrenia is your, I don't want to say typical, like what you would see in a movie of someone with a psychotic illness. That's called positive symptoms. So there's positive and negative symptoms. The negative symptoms of schizophrenia look kind of like depression. You don't want to do anything. You're not really happy. You're not really sad. You're just kind of sitting there, blah. Yeah. So those are the negative symptoms. And then the positive symptoms are the one where you see someone talking to themselves, where you see someone responding to things or that sort of thing. Internally responding to stimuli, we might say, right? Those people are not any more dangerous than any other person. They're not at higher risk of violence, but it scares people.
Yeah.
People are scared of what they don't understand.
Yeah.
And I have to say, some of my patients with psychotic illness have had some of the most profound, interesting things to say. And I operate from a recovery framework. We talk about recovery in substance use disorders, but also in mental illness. There used to be this kind of like, oh, well, if you have schizophrenia, you have it and that's the end. But I've had some of the best conversations about like baseball or like favorite chips. Like you can get someone going and talking about your favorite brand of chips and have this kind of funny, interesting conversation. And at that moment, they're not psychotic. They're not their illness. They're just having a conversation about potato chips, you know? So I try to emphasize that. The key with people with serious mental illness is to be embraced by community. It's important to not be scared. Of course, if someone's making you feel uncomfortable, that's a different situation. But, you know, just kind of, it's regular people, just with a little bit of a different brain process going on.
It's interesting because I told you about that friend of mine, and everybody that was in the room was like, oh, we got to go. And I said, no, we need to stay here just to show that person that we're not frightened by them. It was frightening. I'm not going to kid you, but it was that we're not frightened by them. We'll listen to them, and then when it comes appropriate, we can go home because dinner's over or the wine's run out or whatever.
Yeah.
Is to say thank you very much. So I guess in some ways we did the right thing.
Yeah. I had a neighbor back in Jersey with a bipolar illness, and he was walking around with no shoes on and talking to himself. So in bipolar disorder, you can develop psychosis too. Like I said, everything's kind of a continuum and a spectrum. Yeah. And he said, you know, Kristen, no one's talking to me, and everyone's walking away when I come near them. And I said, Bud, you're scaring some people. They don't understand what's going on in your head right now. So some people find that a little scary. And he's like, really? And I'm like, yeah, they're a little bit scared. So, you know, maybe tell them I got some stuff going on in my head, and they won't be scared. Maybe we could figure out a way that the neighbors won't be scared of what's going on.
Does that person get to a point, though, that they recognize they don't have the shoes and that they recognize that they're talking to themselves? Or is this it's not really curable, just that they recognize that they're different?
Well, it depends. You can offer treatment. You can't force treatment.
Right.
So eventually he did get treatment, but while he was still, you know, grappling with that in his mind, providing a supportive community that it was accepting of him, that he felt safe enough to seek treatment without being stigmatized, was a really good thing, you know? When you feel isolated, isolation is no one's friend. In every single mental health disorder, there's a component of isolation. And that's when, you know, we get a little nervous.
And I would suspect during COVID, this must have been accelerated.
Ooh, yep. Yeah, I had a lot of patients the ones with social anxiety disorders or that have a hard time getting out of their house, they were like, ooh, Dr. Mazoki, you can't make me leave my house anymore. So they were kind of excited to not go out, because usually I do stuff like I haven't gotten to explore the libraries here, but I'm really excited to do so. I'll pull up the library schedule and be like, oh, look, the library has a Microsoft Word class. Would you like that? Maybe let's go to that.
Oh, good for you.
So they'd be like, oh, do I have to leave the house? So now they haven't had to leave the house. So they're happy, but it's also not good for their illness processes. And, you know, mental health, there's been a lot of talk of it's the second wave of the pandemic. And really a lot of trauma, healthcare provider trauma, for sure.
Imagine, yeah.
I am starting to see some clear signs of traumatic disorders coming out. Yeah. From what we've had to kind of do and cope with in the hospital setting.
I can't imagine. The only thing I get worried about is I talk to myself all the time. Mm-hmm. I even answer myself.
Yep. A voice in your head or outside of your head?
Both.
Okay. Okay, well, we could talk more offline.
Yeah, and most of the times I don't argue with myself because myself is always right. Mm-hmm. So I don't have to worry.
Sure.
Kristen, we're getting ready to close.
Okay.
Anything that you'd like to add? I mean, we do need to, real quick, your phone number that they might be able to call to see you or have an appointment or get more information.
Now what is it?
Remember, 779?
778-0035?
778-0035.
I don't know.
But just call the general hospital. And then
they'll transfer you over. I would say that mental health doesn't have to be scary, and it does not indicate any sort of weakness. This is something that so many people walk around holding. And sharing that and being a part of the community, and I think that we can do some work. We can do a little better. If everyone could just get like a little better, then we'll all be in better shape,
and
right?
a little better here, a little better here, a little, and then we look back and say, wow, we've come a long way.
That's right.
Kristen, thanks for coming on the show.
Thanks for having
me.
me.
We'll have you again.
Okay, well,
I'll tell
good.
Ryan, we'll just schedule you for the regular. We'll go through some of this other stuff. I mean, this is fascinating to me because, again, I go back to just because I look great doesn't mean I'm great.
Oh, yeah.
And that people have to recognize this. And we all have bad days. It's just sometimes if the bad days go on longer and longer, don't be afraid to seek help.
That's right.
So I would encourage people to do that. I've done that myself personally. But thanks for coming on the show.
Thanks so much for having me.
Hey, we'll see you next time on Talkin' Maine.